Hey, you guys speak now?
Dystrophies, hoje que eu faço.
لا ما عندي سؤال بس عادة لأنه لو كنت عارفة لو شو بدهم exact كنت عملت
لا, whatever we have, this is it's kind of like in some places you have levels in one column, other patients you have it in a different column.
I'm going to here on Monday in the afternoon for neurovascular. So I'll load the picture and I send the email.
Okay.
And
who's kind of covering for you?
No one.
You need to deputize somebody to kind of talk about
Ayman will do it.
Okay. Yeah, I'll talk to Ayman then. Morning, Dennis.
Morning.
Is the sign-in sheet back over there? I hear.
Can I have it ready?
Aline, who will MD
So it's me, it's Ayman, Harsh, and Kosto. Since I told the guy that we have just 7 patients, I told Ayman not to come because he has the inpatient resident, so we're going to be 3 there, but there are 7 patients. Yeah. So I just told him.
News? Any news?
From
We read the newspapers.
Morning.
this is in a liberal.
Missed your lunch Wednesday. Yeah, I desperately need to go. My education is really falling down. We had some very interesting sessions. I'm sure you could have contributed.
Russia sold Azerbaijan.
No, I'm so far behind. I'm purely in the learning.
I mean, they have a lot of money.
If you're going to study,
So they're wanting to use them. Take it back. See what happens.
It could have the potential to do it. But that was not good.
The problem is they usually get a lot of jihadis to now the
They are
jihadis
It's a season.
Bad timing. They had the last war they had Afghans.
now Dr. Skinner every once in a while sends something to
They're used to fighting in the
educate
mountains.
me.
Unfortunately, the
I
mountains
really
were not
enjoyed
the
the one
most
he sent. I forgot the guy's name. That had all these
local guys do better.
sayings.
It's
I don't
But the visual is falling
Oh, I
apart.
bet he did so.
Yeah.
Maybe you thought you were too busy to read.
I always thought the
I do
Peshmerga was
too.
very powerful.
Bugging the heck out of me.
No, they're
I start every day with a list
they are
of
good
things
enough,
to
but
do.
they're good enough to fight this around.
Otherwise, I'd never.
You know, actually, what I think Turkey needs to get in. Because they're going to turn on them sooner or later.
Another thing about getting old,
Turkey would
I
be
don't
good
like
with
noise.
with the
If
Arabs.
my water is, if my wife is
Turkey
flattering,
would be a
China.
chip stick muscles and
Kitchen. drives me crazy. It's so loud.
But that's actually what seems to be the reason.
Well, see, that means you're hearing
Yeah,
it.
but they need to kick them
I,
out.
in fact, I started wearing hearing aids today. I can hear the speaker usually, but if there's somebody
think-
comments
And the
on it.
Yazidis, there are a lot of Yazidis.
I hear noise, but I don't understand. I think I've got bad going on.
Yeah, exactly.
They're very peaceful. They
Well,
don't
you
harm
probably
anybody. They're
need
nice
to
people.
But that's the case in Iraq.
Yard.
They are very quiet.
Well, next week I'm here next week. The following week I'm going to go to Colorado and
Who knows how it's going to be.
visit my brothers. So that'll be a real vacation.
Well, you know, Dick Clark just came back.
Well, I think the United States
He was
needs
in
to
Durango. He told us all about riding the Durango
They're
Silverton
the
Railroad.
only
And you missed out.
Yeah,
strong
that's true.
Have you
That's
read
what they were trying
ridden
to
that road?
everyone
Oh,
on the
it's a
news.
wonderful
They only
ride.
have to support that.
It's a narrow gauge, goes up this valley.
The Kurds are very good fighters.
Yeah.
It's got a roaring river. It's
They are the ones who lose by the first
They're not the settled Kurds, the nomadic Kurds.
That's true.
The settled Kurds actually helped the Armenians escape.
Settled Kurds are usually in this neighborhood. That's the thing.
Do you know where their scene is?
No.
Their scene
One
is just
summer we took
east
the
of
kids and tried to ride every railroad in Colorado.
what's now Elazığ.
And there's the village town which shows back
Mawrat al-Aziz.
and
And if you go to like any Armenian church,
Durango
you ask them, what is your
Silverton steam
ancestors come
railroad.
from? They'll
And then there's
say
a couple more.
the main town escapes me. But the reason that they all have their descendants in America is because the Kurds protected them and they escaped to Iran.
That's the case in Damascus, where they like 100 people. I'm not sure what they call them. In Syria, we call them just Kurds. They are the ones
Well, the Yazidis are Kurds also. They're Kurds. They just never changed. They never accepted Islam.
Oh yeah, well, but it was not my boss. Oh, it wasn't? No, it was a cruise. A cruise? Oh, yeah, like 2,000 people there. Like crazy.
Morning. So today I'm going to be just covering quickly muscular dystrophies. It's a big topic, two multiple different types. A few months ago, Dr. Gandugu talked about myotonic dystrophy, and that we're going to see that's one type of these multiple dystrophies. So if we're going to start with the skeletal muscle, it's built from units, and the smallest unit is the myofiber, or the muscle cell itself, that group together as a fascicle. Surrounding this myofibers, we would have the connective tissue that we call the endomysium. Surrounding the fascicles, we would have the perimysium, which also a connective tissue that would have the blood vessels mostly over there. And surrounding the whole muscle, we have the epimysium. So it's kind of like a unit-built muscle. If we're going to go smaller, so we talk about the smallest unit is the myofiber or the cell. That's where you're going to see this picture that you remember from your physiology classes. And that's the cell. So we have the nucleus, which in the muscle cell, it's usually in the periphery. And we have the cell membrane, or what we call sarcolemma. And then we have the units, or the myofibrils. And that's where we're going to see the actin and mucin. That's what you remember. Surrounding that, there's tons of mitochondria and what we call the T-tube, the one that you have the action potential getting deeper in this unit. And if we go even deeper, now talking about the actin and myosin, That's what you remember as this kind of unit. What we call a sarcomere is the small unit between two Z discs, and it has the myosin in the middle and the actin that kind of like overlap. So there's tons of proteins in the muscle, and each one, if it's affected, will give you different type of muscular dystrophies. Now, say goodbye to a normal muscle looking. Everything else you're going to see will be abnormal. So this is how muscle pathology will look like in a normal case. And as we said, it would be kind of fascicle built, different myofibers. The nuclei will be on the periphery of this myofibers. Different staining will give us this, what we call checkerboard appearance. So these myofibers are not exactly the same type. There is at least 3 different types of myofibers, 1, 2A, and 2B. Now, that will depend on how much these myofibers will have from lipids or glycogen, how much mitochondria in there, what kind of metabolism these myofibers will use mainly. All of that are driven by what kind of motor neuron like innervate these myofibers. So to be efficient, these myofibers should be spread throughout the fascicle, so it will not be grouped together. And so if you have a focal injury or something, it will not affect multiple myofibers. So that's a transverse cut in the muscle. If we take a longitudinal cut, now we're going to see the myofibers on the long run. So we're going to see the sarcolemma, or the muscle membrane, myofiber membrane. We're going to see the peripheral nuclei. And that's where we're going to see, as we see at the I band or the A band, the myosin and actin. So when do we do muscle biopsy? Muscle biopsy is very essential to do a differential diagnosis, like to get to the diagnosis of muscular disease. But really, it's losing its importance toward more genetic testing, depending on what kind of disease we are talking about. So with inflammatory myopathies, we still depend on muscle biopsy because that's the easiest way to get to a quick diagnosis. While in muscular dystrophies, we're going to see that there's nothing very specific for a lot of these muscular dystrophies when we do the muscle biopsy, and then we're going to end doing the genetic testing. In general, we do muscle biopsy when we have something objective in our hands, an objective weakness, an elevated muscle enzymes, and abnormal EMG. So on the other side, if you have only subjective weakness, just myalgia, and if you just have mildly elevated CQ or aldolate, your muscle biopsy will not be very helpful. How do we select what muscle do we need to do the muscle biopsy from? That will depend on the clinical exam. So usually we go for mildly weak muscle involved. 4 out of 5, I would say, is the fair number to say this muscle will be a good muscle biopsy. If you go for a very good muscle strength, 5 out of 5, you might be missing the pathology. If you go for a very weak muscle, like 2 out of 5, muscle strength I'm talking about here, it will be a very burned out muscle that you will be just a burned out muscle. So a clinical exam, MRI findings, and a lot of time we also depend on the EMG guidance. Now, if you heard us doing an EMG on a patient and you want to do a muscle biopsy, don't do it from the same muscle that we did. Do it from the other side, because you don't want to end having an artifact from our needle test, unless if you're doing a needle biopsy. Muscle biopsies. So usually we go for a big muscle, and usually you go for proximal muscles, because that's where you can have more of the pathology findings. And as we know, most of the muscle disease will be affecting proximal muscles. Now, in special cases, we have to go to the distal muscles, like TA or gastrocnemius, if you have a distal myopathies, which usually we try to avoid because you don't want to be kind of misleading your findings with a subsymptomatic old radiculopathy. Classification of muscle diseases. So we talked last year about acquired or inflammatory myopathies, and that's include the polymyositis, dermatomyositis, inclusion polymyositis, necrotizing myositis or myopathy, and sarcoidosis, infectious myositis. We have a different type like toxic myopathies and endocrine myopathies. So that's an acquired things, while today we're going to talk about the dystrophies, the inherited disorders. Beside the dystrophies, we have the congenital myopathies, Neumann rods, central coram, central nuclear, and we have the metabolic myopathies, mitochondrial disorder, glycogen and lipid storage, and all this channelopathies. Very quickly, before we start with muscular dystrophies, just a couple of slides from what we talked before about inflammatory myopathies. So the big differential here will be the clinical picture. And inflammatory myopathies, dermatomyositis, polymyositis, is usually the subacute chronic, couple of weeks, couple of months presentation of weakness and myalgia. If it's very progressive, very bad, you will get to see respiratory problems. You will get to see dysphagia. And not always, but most of the time you're going to have elevated CK. But usually the CK with inflammatory myopathy will not be very high. It will be just about like up to 10 times the normal. So if the normal is 200, 300, that would be maximum of like a couple of thousand. But as you say, sometime you might not see elevated CK. So inflammatory myopathy is an acquired disorder, except for a few forms of inclusion body myositis that can be running in the families, while muscular dystrophies are usually the hereditary disorders. We saw the normal muscle back here. Now we're going to start with the pathology. Polymyositis, you're going to see a lot of inflammatory cell inflammation in the endomysium here, and invading the myofibers, eating up the myofiber from inside. That's what we see with polymyositis. And dermatomyositis has this typical picture of perimysium inflammation and perifascicular atrophy. That's a different picture of dermatomyositis, and as we said, the perifascicular atrophy and perimysium inflammation that you can see very clearly. What I'm talking about, look deep in the muscle, you will see a normal size myofibers, while in the periphery you will see more smaller fibers invaded by the inflammatory cells. Inclusion body myositis, that's the chronic form of inflammatory myopathies. So we're going to see inflammation like what we see in polymyositis, but we're going to see also the big myofibers. We're going to see the vacuoles. That will look ring vacuole, different staining, and these vacuoles will have trash, including amyloid. So it's a chronic degenerative disorder, and that's why we don't treat inclusion body myositis. So that was just a quick view of different type of inflammatory myopathy before we start with muscular dystrophies. So the big differential will be if you have a patient with subacute to chronic, few weeks, few months presentation of muscle weakness and myalgia, that's likely inflammatory myopathy, especially if they fit with the age. While muscular dystrophies, it's more of the very, very chronic, very slow progressive years. Muscular dystrophy will have family history most of the time, while inflammatory myopathy, most of the time you will not have any family history. So muscular dystrophies, we're going to cover a few different types. The dystrophinopathies, Duchenne and Packer's, myotonic dystrophy, the FSH facioscapulohumeral muscular dystrophy, the Emery-Dreifuss, limb girdle, which is by itself a group of multiple one, oculopharyngeal and distal dystrophies. So we started with a big unit, the muscle, the fascicle. We went to the myofiber, and we said inside the myofiber you have the unit of actin and myosin. Now we're going to make it a little bit more complicated. So you remember the actin that we had back there, and you remember the plasma membrane or the sarcolemma. Now, in between all of these, to have a functional muscle, you have to have a lot of functional protein. The first one we're going to start with will be with the dystrophin. The function of the dystrophin is basically to link the actin to the outside matrix, so to give stability for the muscle. So dystrophin is a good protein. When you lose it, that's where you're going to have the disease. It's an X-linked recessive disorder, so you're going to see it in boys. Woman will be carrier for it. It's a deletion of the dystrophin gene, and it's an out-of-frame mutation in Duchenne, which means that we're going to have a complete loss of the dystrophin. About 1/3 of the cases will be mutation, no family history. Onset of the weakness usually in 3 to 5 year old. Now, if you go back in the history, the family will tell you that actually the kid was very delayed and start walking and moving, and he's slower always compared to other kids. It's a very slowly progressive disorder, but usually by the age of 10, 15 maximum, they will be in a wheelchair, and they will die in their 20s. The death mainly because of respiratory insufficiency or cardiac failure. So the clinical features, as you say, delay milestone, like motor milestones. These kids also will be slow, mentally slow, most of them. Usually they will be walking with this kind of specific myopathy, or the waddling, and they will have the Gower sign. As you see here, the kid will need to climb on their legs, standing up. And the other thing that you will have a specific finding on this patient, they will be standing with hyperlordosis of their back. Big calves. So whenever you see a kid having trouble walking and have big calves, think about Duchenne, especially that it is the most common muscular dystrophy. The incidence is about like 1 per 3,000 to 4,000. So it's really a common muscular dystrophy. The big calves because of pseudo-hypertrophy. So mainly with time, this muscle will be degenerating and replaced by fat tissue. It looks like as if it's big, but it's really weak. And they will cause contractures in their heels. As you said, hyperlordosis, scoliosis, and most of the kids will be slower mentally. Cardiomyopathy is a big problem, and it's one of the main causes for death. So if you remember, we said with inflammatory myopathy, the CK will be not very high. It's like 1 to 10 times. I'm going to always report the CK this way, multiplied by normal. So if the normal CK is 200, 300, we say inflammatory myopathy would be 5 times, 10 times maximum, while in Duchenne muscular dystrophy, it's up to 100 times the normal. So that's where you're going to see the huge number, the 40,000, the 50,000. And that will be in the first, kind of like up to when they are teens, because later on the muscle already degenerated and the CK will goes down. We can do the gene testing on Duchenne. Not anymore, we need a muscle biopsy, and it's positive in about 90% of the time. Still, previously we used to do muscle biopsies, and we're going to see this variation in fiber size, too much of connective tissue, and degenerated myofibers. So, you remember the normal picture, myofibers are very close to each other, you don't have too much of the endomysial connective tissue, while here, inside the fascicle, there would be too much of endomysial connective tissue. The myofibers will start to degenerate. Now, this is not inflammatory cells. These are small nucleus coming close to each other. So we say the nucleus usually in the periphery of the myofibers. When you have a degenerative myofiber, it shrinks together, and the nuclei will come close to each other. And then you're going to have some macrophages to eat up these degenerative fibers. So this is a younger kid. This is a little bit older kid. So you're going to see that now we have a more degenerative fibers. We have the chronic changes. We have the big fibers. And we have replacement of too much of the muscle with the fat tissue. Treatment or management. We don't have any treatment for Duchenne. We say most of all the kids die when they're in their 20s. If they're lucky, they'll live a little bit longer. The only medicine that we use now for Duchenne is prednisone, and different way of giving prednisone. But the best way, I would say, is weekly. And usually we do 5 to 10 milligram per kilogram over the weekend, like kind of on the age and the size of the kid, either 1 day or 2 days. Some other people still do it daily prednisone. We know that prednisone will prolong mobility. So instead of patient or the kid being in the wheelchair when they are 10, they might still be walking till they are 12 or 14. Questionably, also, it might help the cardiac function or respiratory function. But really, there is no changes in survival. So they still die in their 20s. We usually are very aggressive in using the non-invasive ventilator, the pipette, for these kids, and cardiac management for their arrhythmias and cardiomyopathy. Now, new therapies are the gene replacement, trying to inject in genes that can replace this dystrophin. And hopefully it's going to be out a few years. Moving from Duchenne to Pecker. It's the same thing. It's X-linked. It's the same dystrophin gene. The difference is in-frame mutation instead of out-frame mutation. So instead of completely absent dystrophin, you're going to have just a decrease in the dystrophin. The incidence of Becker is much less than Duchenne. Onset varies, but usually it's a little bit older ages, 10, 15-year-old. Some people, if they are lucky to have more dystrophin, they will be symptomatic when they are 20s or 30s. Usually they continue to be walking till 20, 30, and still they die within the 40, 50 years. Cardiomyopathy and mental retardation is less frequently seen in Beckers. So they might look normal till they are 20s. The CK is that high, but not as high as the Duchenne. Muscle biopsy, we're going to see the same kind of changes we saw with Duchenne, but the difference would be when we're going to do the immunostaining for dystrophin, it will be different. And also we have an available genetic testing. Really, there's nothing specific about the management for Beckers, and there's no indication for prednisone in these kids. That's what we do with immunostaining. So a normal case, so remember we say dystrophin is a protein just under the sacrolemma that connect your actin to the external matrix. So whenever you're going to do the immunostaining, you're going to shine up the membrane of the cell, the edge of the cell. So that's the normal staining for dystrophin, the immunostaining, and it's going to shine up the edge of the myofibers. If you take a Duchenne patient, you'll see that it's completely lost. If you take a Becker muscular dystrophy patient, you'll see some trace area. If you take a mother of Duchenne kid, so she's a carrier, and it will be just a patchy loss of the Duchenne or dystrophy. So moving from the most common one, Duchenne muscular dystrophy, to Emery-Dreifuss muscular dystrophy. The defect here would be in the nuclear membrane protein. So we started there by talking about the dystrophin. Now we are going deeper in these myofibers. And it's specifically affecting Emerin or lamin. And the Emerin form will be X-linked, while the lamin will be autosomal dominant. And usually the presentation will be in their 20s or 30s. Very slowly progressive, what we call a hemoroperoneal weakness. So proximal weakness in the upper extremities, foot drop on the lower extremities. Kids who have early onset, they will have contractions. And the specific thing about Emery-Dreifuss, why these kids or why these men would be walking, they would have contraction. They would have like a rigid spine, and they would have contraction in their elbows and their ankles. Cardiomyopathy is also seen, and as we talk about Duchenne, cardiomyopathy also seen in the carrier, like the mothers. You remember that picture we had about dystrophin and how it's connecting the actin to the external matrix? Now we're going to make it a little bit more complicated. So we start with the plasma membrane or sacrolemma. We have a nucleus down there, and we have the actin, and we have the external matrix. Now there's tons of protein in between all these compartments that make your muscle function very well, and each one would be affected with different type of muscular dystrophy. Here we are talking about Emery-Dreifuss, so we talk about dystrophin, we say Duchenne and Becker muscular dystrophy. And Emery-Dreifuss, we're talking about nuclear protein, the Emerin or lamin. And each one will give me either an X-linked Emery-Dreifuss or autosomal dominant, sometimes autosomal recessive. CK will be high, but not that high, not like Duchenne. And as we say, it is very slowly progressive disorder too. EMG would be myopathy. The muscle biopsy, nothing specific about it, but we can still do the immunostaining for the Emerin. And as we said, it's a nuclear protein, so the normal case will shine up your nucleus, while in a kid with Emery-Dreifuss will not show that. Moving to the big group of muscular dystrophy, limb-girdle muscular dystrophies. Now, we split it down to autosomal dominant and autosomal recessive. Autosomal recessive is the most common one. We see a lot of the cases compared to the autosomal. Altogether, it's very rare muscular dystrophy. The recessive form is more common in the younger ages. It's very severe, very aggressive. The CK will be very high, while the autosomal dominant will be on the other way. More in the adults, milder cases, And the list is getting longer and longer. I have to split down the table to 2 slides. So limb-girdle muscular dystrophy. Type 1 is the autosomal dominant. And we started with A, B, and we are going all the way down. Different types will give me a different clinical picture, but altogether it's limb-girdle. Limb-girdle. What we're talking about limb-girdle is proximal muscle weakness in the arm and legs. We're going to see that there's types that have distal weakness with that. Type 2 is the autosomal recessive. So it's the most common, it's the more aggressive, it's the highest CK that you're going to see. The most common form of all these limb-girdle altogether that we see is 2I. And it's the FKRP gene, and it's most common altogether. It's about like 20% of all this limb-girdle muscular dystrophy. The other common types we see 2A and 2B and 1A. Back to this picture. So dystrophin, Duchenne and Pecker. Emery-Dreifuss, we talk about the nuclear protein Emery and Lannon. Now we're going to talk about the limb-girdle muscular dystrophy. So the most common one we say 2I, and it's actually a Golgi protein. We see 2A, and it's the calipin. Calipin is a protein that helps the actin to be more kind of stable. And we see all these different types. So the dystrophin, as we see it, is connecting the actin to the external matrix. We have something called sarcoglycan complex, and each unit by itself can give you a different type of muscular dystrophy. So that's why all the clinical picture will look about the same, because it came with the same complex. Some of them can look like Duchenne muscular dystrophy, because if you lose the dystrophin or if you lose that complex, it can give you the same picture. But different outcome, they will not die. Now, if you remember, we talked about the sarcomere, which is the unit between 2 Z lines. We have the actin, and we have the myosin. And inside the Z line, inside all these proteins, we have the extra protein that's supported, and each one by itself will give me a different type. So as we talk here about the calipin, it's a protein that actually just supporting the actin altogether. So if you lose it, as if you're losing your actin. When we say a Z line or Z disc, it's not a simple thing. It's tons of protein, and each one by itself can be affected, and each one can give me different diseases. So, not the most common, but it's the most common autosomal dominant form. It's the myotelium. The onset in 20s and 30s, so more adult age. It's slowly progressive, not as severe as aggressive as the 2. This one will have distal weakness, and they will have ankle contractures, so kind of similar to what we saw with Emery-Dreifuss. The specific thing for 1A will be dysphonia. So these people will have trouble with their speech, and cardiomyopathy. 2A, it's the most common form we see in Italian and Spanish descended people. That's calipin 3, the one next to the actin. The onset is more younger ages, as you say, autosomal recessive. We are in type 2 now, so autosomal recessive, younger ages. CK will be very high, 10 to 100 times of normal. They have a specific finding of scapular winging, and they don't have much of calf hypertrophy. 2B, or dysferlin or Myoshi myopathy, the onset in their 20s. CK would be high, and the specific thing for it would be they have distal weakness, and very interestingly, they have gastrocnemius more than tibialis anterior. I don't think there's multiple like diseases that can give gastrocnemius weakness more than tibialis anterior. 2I, it's the most common one that we see in Caucasian people. Onset 6 months to 30 years, so a very big range of onset, very big range of clinical spectrum. But they have early onset. That's where they're going to lose their mobility when they are 10, 20. So they look like Duchenne. They will have big calves, but they don't die. They live much longer. Finishing the limb-girdle muscular dystrophy, now moving toward oculopharyngeal muscular dystrophy. It's an autosomal dominant, as it sounds, oculopharyngeal. It's a GCG expansion of this protein. We have 2 genes that can give me the same disease, and onset usually is very delayed, therefore the 5th decade. Clinical pictures, they will have ptosis, they will have extraocular movements, They would have dysphagia and not much of like arms and legs weakness, so kind of a very mild neck and proximal extremity weakness. CK will be mildly elevated because it's basically affecting small muscles. It's not going to the arms and legs. Muscle biopsy will give me subsarcolemma rim vacuoles. And very important here to do the muscle biopsy because this is a differential diagnosis from mitochondrial disorder. As we see, eye problem, the dysphagia, that's what we see in mitochondrial myopathies. The pathophysiology is too much protein building inside the nucleus, cupular filament inside the nucleus itself. Symptomatic management, ptosis surgeries, eye muscle surgeries, and cutting the upper esophagus sphincter or placing a feeding tube. We talked about dystrophin, we talked about Emery-Dreifuss, Emerin, and Lemon. We talked about the most common limb-girdle muscular dystrophy 2I, the 2A one, and that's where oculopharyngeal will be. It's on this protein inside the nucleus. When you have a mutation in that gene, you're going to build too much garbage in that nucleus, you're going to kill it, and it will give you that picture. Facial scapular humeral muscular dystrophy, just described. It's a facial, scapula, humeral, and this patient will also have foot drop with that. I think they didn't squeeze the knee there. It's a D4Z4 deletion, autosomal dominant, and the onset usually in the 20s, but these people might present at any time. Actually, I have one patient who was on basketball scholarship and was doing very well till she was like in her 40s when she started developing the disease. It's the third most common muscular dystrophy. So we see Duchenne is the most common altogether, but that's in kids. And the second one is myotonic dystrophy. And FSH is the third most common muscular dystrophy. It's very interesting to be asymmetric. So usually would expect with degenerative disorder to be symmetric. And muscles. Now, ALS is definitely asymmetric. Parkinson is asymmetric. So FSH is asymmetric. So if you see a patient with scapula winging in one side, not on the other, and there's no history of trauma, look for foot drop and look for facial weakness. And it's very common. The incidence is about like 1 per 10,000. So it's not very common, but it's the third most common muscular dystrophy. So they would have facial muscle weakness. These are the people who tell you they sleep with their eyes open. They have transverse smile, and they have difficulty drinking using the straw. And they have scapular winging. They have weakness in the scapula. And the scapular winging is the one that will give them the trouble lifting their arms. So actually, interestingly, they have humeral weakness. They have biceps, triceps weakness, while they don't have much of deltoid weakness. While the patient main complaint would be, I cannot lift my arm, because basically they lost the stabilization of their scapula. So when we support the scapula on the back of their back, they will be able to lift their arm and have like even a deltoid 5 out of 5 muscle strength. A lot of these patients would have also foot drop. TA would be weak. Only 20% would have proximal weakness in their legs. As we're going to see with myotonic dystrophy, the most common one, you would have cataract, while in FSH, you're going to have retinal vasculopathy, and they would have hearing loss. Usually, they live a normal life. They don't have any cardiac or respiratory involvement. Still, whenever we make the diagnosis, we still do the cardiac and respiratory workup as a baseline. That's how scapular winging will look. And they have the interesting look of what look like a wings on their shoulder because the scapula is kind of attached down. And they would have what we call the triple hump sign. So they would have the scapula jumping up. They have the humeral head. Actually, what you see down here is the deltoid. And that's a normal mass. So it's really a normal muscle bulk and normal function. Whenever you just support their scapula back there, basically just put pressure and support it anteriorly and posteriorly, they will have a normal function of their deltoid. FSH, DCK will not be very elevated, and muscle biopsy, it's one of the few muscular dystrophy that would be kind of misleading because it would have some inflammatory cells. But when you have the clinical picture, you have a family history, this inflammation doesn't mean anything and it doesn't respond to any treatment. Finishing with myotonic dystrophy. It is the most common adult form of muscular dystrophy that we see. It's autosomal dominant. We have two different forms, DM1 and DM2. DM1 is the distal weakness, DM2 is the proximal weakness. The onset usually in the 20s, 30s. Sometimes we would be surprised with it. We had a patient here in the ICU, trouble extricating. And when we examined her, she had muscle, like facial muscle weakness, and she had all the temporal atrophy. So frontal balding, temporal wasting, DM1 distal, DM2 proximal, muscle weakness, neck weakness, and that's why we have respiratory problems. Pharyngeal weakness, dysphagia and dysarthria. Myotonia, we are calling it myotonic dystrophy. Myotonia is a problem in the relaxation of the muscle. So whenever you're going to shake hands with this patient, they're not really messing around with you, just simply they cannot release it. And we can see that by doing percussion or just asking them to make a fist and release it as fast as they can. And myotonia, they would go very slow. They would have respiratory muscle weakness, and quite a few of them would have mental retardation. The big thing about myotonic dystrophy is the systemic involvement. So these people will have diabetes, they will have a cataract, they will have arrhythmias. So we send these people to see a cardiologist once a year and to see an ophthalmologist once a year. They have a special thing about their cataract that it's a posterior capsule. It's like a Christmas tree whenever you're looking at it. Myotonic dystrophy CK will not be very high, 1 to 5 times the normal. We can hear the myotonia when we are doing the EMG. And the muscle biopsy, also nothing very specific about it. So we don't do it anymore. We just go for genetic testing. Annual evaluation by cardiologist and ophthalmologist. Basically, after we see them, and the first thing we have to treat usually is this myotonia is painful. They have pain in their hands, they cannot relax it. Dilantin worked very well, or carbamazepine worked very well for it. The big thing that we have to do is just simply send them to cardiologists. A lot of them, they have arrhythmias and they need to be intervened about it. And cataract evaluation. Finishing with a very rare one, Al-Lahham myopathy. Actually, I think Dr. Lucy has one.
He died.
Died, okay.
I should have asked him eventually.
It's also dominant. Now, we started with the picture and we make it very complicated. We start from dystrophin and going to the nucleus and going to Golgi. Actually, Al-Lahham myopathy is not even in the muscle itself. It's collagen 6. It's external, extracellular matrix problem. But we say we need the dystrophin to connect the extracellular to the actin. So if you lose the dystrophin or you lose anything of the actin, the same thing is going to happen if you lose the extracellular matrix. Onset 10 to 30s. It's a very slowly progressive, proximal more than distal weakness. They would have a specific finding of finger flexor contractions. And they would have follicular hyperkeratosis. They don't have much of facial weakness or muscle hypertrophy. Normal life expectancy with no cardiac or respiratory involvement. Was he an old guy?
Yeah, he was pretty old. He died here. I don't think his death was related to the myopathy.
And the CK will not be very high.
Is this named after the hospital in England, the psychiatric hospital? Then the name is misspelled.
No, it is this way. It's like Al-Lahham, but this is the way they spell it, unless it means something else. So back to this picture. We said dystrophin, which is a good protein. You need it, and it gives you Duchenne or Becker if you lose it. The actin, you would have the calipin-3, which gives you a limb girdle. You would have the most common limb girdle 2I if you have a Golgi protein problem. You have Emery-Dreifuss with contractions if you have nuclear protein problem, either laminin or Emery. Epilepharyngel, it's too much garbage built inside the nucleus. And different type of limb girdle muscular dystrophy. And we're going to end with Al-Lahham myopathy, and it's basically just outside the whole cell. We can do immunostaining for this collagen thing, And on the left, you're going to see a normal muscle, normal case. Everything on the red is collagen here. So you're going to see some collagen in the interstitial, or what we call endomysial tissue. And you're going to see a very sharp line surrounding each myofiber. And that's basically the collagen just over the cerebellum, and that's unique to connect to the actin. In patients with Al-Lahham myopathy, you're going to see tons of this collagen, but actually it's just in the endomysial connective tissue, so increase in the intraconnective tissue, while this line around the myofibers is becoming very thin and kind of losing a lot of collagen. So basically, even that you have a lot of collagen, but it's misplaced in the wrong place. So that's basically it, a quick review for muscular dystrophy, just a couple of cases. A young boy with proximal weakness and large calves. What do you want to do? A proximal muscle or gastrocnemius muscle biopsy?
Proximal. Neither.
What?
Neither.
Yeah, exactly. So why do you say proximal? CK. What do you want? Arwa.
Yeah.
Take it. What do you want to answer?
This is most likely Duchenne. So CK will be like 10,000 folds. No need for muscle biopsy, and just to confirm, genetic testing.
Genetic testing, so you don't need a muscle biopsy. For this kind of it's a clear-cut kind of diagnosis. You don't need to do any muscle biopsy. Just go for less invasive procedure, genetic testing. Now, I didn't give you the age for this boy. He might be 15 and still walking, so then it's Pecker, not Duchenne. Another case, 32-year-old man with subacute onset severe myalgia and muscle weakness. The CK is 18,000. Physical exam, you have deltoid, triceps, hip flexors, and quadriceps 2 out of 5. You have biceps 4 out of 5. You have distal muscles, hands and legs 5-, but he's really in pain. EMG outside hospital, they did a myopathic process. What's your next step? He's now, and actually, he was just admitted yesterday, and they called me to repeat the EMGs. Not just kidding, but what do you want to do? Who's on service? Need options? Muscle biopsy? The surgeon will tell you, I will try to squeeze him in today, but most likely I will do it Monday. You want to... Someone give me an answer. CK 18,000, and it's subacute. The guy's telling you start having the weakness just like early this week. Last week.
MRI of the muscle.
Do we have any radiologists around here? So MRI is really good for muscles, but unfortunately we have no good luck in people reading MRIs over here. They overread everything. From muscle strain, because everything looked the same, edema in the muscle. So unless you have an MRI that tell you these patients have increased signal in their extensors muscles or their flexors muscles, then that's specific. Otherwise, it's kind of misread.
What's a SID rate?
I don't have it.
Well, take him off his
So let's say SID rate was 40. He's young, man. 32 is a big 40.
Is he on a statin?
No, 32. But he was drinking a lot last week. So basically, in this case, whatever the diagnosis is, can be anything. It can be toxicity from medication. It can be toxicity because he was drunk and he slept on the floor for like 2 days, unresponsive. Or it can be inflammatory myopathy. The guy had a skin rash and everything fit with dermatomyositis. Or basically it can be a muscular dystrophy that he was not aware of it. You went, examined him, and yes, he took some statin now, but you saw facial weakness and you show scapular winging. So it can't fit with everything. In this kind of cases, do not do muscle biopsy now. You're going to end with just garbage. The muscle biopsy, I would wait for at least 2 or 3 weeks till I would do the muscle biopsy on this case, or these people. Because you're going to do it, like, they have rhabdo. So what's the muscle? Even the EMG, I would not repeat it on him, or do even an EMG, because you're not going to tell me anything more than what I know. He has proximal weakness, and he has a rhabdo. Where is this rhabdo coming from? From his muscle. He definitely have a muscle disease. That's where I would just sit and say, I'm going to follow you clinically. If you need fluids, we'll give you fluids. If you need dialysis, I will clean your CK. And I will repeat the blood test and repeat the EMG and consider muscle biopsy in 3 weeks if you're still weak or your CK never went back to normal. So whatever the cause is, if it's toxicity or trauma or if it's inflammatory myopathy, muscle biopsy now would be really misleading because you're going to end just seeing a lot of degenerative fibers, which you know from the CK.
So I guess, that's all supportive. I guess the question would be, what if he continues to weaken? Would you treat him with steroids or worry about it being a viral myositis and not?
Now, that's where the other blood tests would come. So if you see that he had a skin rash, if you see that he had an inflammatory picture, that's an inflammatory myopathy. If the story is not just 1 week, if the story a couple of weeks and you have everything else and there's no trauma and there's no toxicity, then yes, that's an inflammatory myopathy. I will start treating. Muscle biopsy in this case, with this kind of 18,000, really will be just a degenerative muscle. So you're not going to see even inflammatory cells. You remember we saw the polymyositis and dermatomyositis. It has a special picture, each one. So if I'm going to take a muscle biopsy from a guy with a muscle strength 2 out of 5, too much weakness, CK of 18,000, it's going to end just being filled with everything.
So if it's a necrotizing myopathy, being subacute or kind of rapidly progressing,
then possibly medication.
What's that?
Medications, toxicity. Necrotizing myopathy usually is triggered by something.
And the treatment, is there any different treatment that you would use for that?
So necrotizing myopathy, we are talking about, the most common one you see with is statin. Now, statin can give you just toxicity. If you stop the statin, it goes away within a few weeks. But let's say, yes, this guy was started on statin because his grandfather died with a heart attack last week and he was scared and started on statin. I will stop the statin. In 3-4 weeks, if his CK went down, but stay for 5,000, he still have a muscle disease. That's necrotizing myopathy triggered by something, and that's an autoimmune disorder. We can do the muscle biopsy. Actually, the antibody is available now, so we can just check the antibody. But yeah, these are the people. In subacute cases, I would say very helpful to do the muscle biopsy. In more chronic, I would depend on the kind of like what pictures do we have. For necrotizing myopathy with statin, these people will depend on steroid. So they will need to be on steroid. Every time you try to wean it off, they start having, again, myalgia.
So you will not start steroids in the acute phase?
Yeah, if you have the picture, if you have the clinical picture, I will start treatment. I'm saying I will not do the muscle biopsy. If you have a clinical picture, you will start treatment. Questions?
Why the pathology always goes with the dominant type 1 at like the old dystrophies, all despite that they have the dominant type 1 at.
So, yes, that's true. Most muscle diseases would affect type 1. Now, and that's why actually we try to do muscle biopsy for muscle that we know. We do quadriceps and we do deltoid because we know the ratio usually is about 60-70% type 1 and 30%, 40% type 2. While other muscles might have a different ratio. Type 2 more dominant, or there's no muscle that type 2 is very dominant. Now remember that we say type 1 is the dominant muscle fiber in most of the muscle. It's the one that metabolize lipids. It's the one that carry you. It's the one that lifts all the weight or whatever function that you're doing without fatigue. While type 2 is the one that you use just for quick actions and fatigue very quickly. So it's the dominant one.
The cardiac lesions were mentioned a lot of the time. What do the cardiologists do, and does this ever go to cardiac transplant?
I don't think anyone would go, so the cardiomyopathy that we see a lot is with Duchenne. And unfortunately, these people, because anyway they're going to die from respiratory problems, I don't think anyone have done cardiac transplant. Most of the other cardiac involvement will be mainly arrhythmias. Now, they're going to have cardiac myopathy too, but the arrhythmias will be the one that is more dominant. Actually, I was thinking about throwing a couple of slides to summarize cardiac involvement, but I don't think we would have time.
Tawfiq, does anybody have a theory why the Duchenne patients have mental retardation or whatever. I mean, there's no dystrophin in the brain.
No, there is. So dystrophin is in the brain, and it's...
What does it do?
And it's, I don't know what does it do. It's mainly in two different, or like few different places. The highest concentration of dystrophin would be in the cortex and in the hippocampus. So the hippocampus, I would say, is where you're going to have seizures, or we're going to have your memory built too. And that's why some types of Duchenne will have mental retardation. They will have very bad mental retardation. And some other types will be really normal. About 25% of Duchenne kids will have normal mental status. And that's depend on what different isotope or isoform of dystrophin will be affected.
As a continuation to this question, you listed a lot of proteins. Most of them do not look like cell-specific or muscle group-specific. Is there any explanation why in certain diseases you have distal myopathy and others proximal or even more localized?
Like these proteins, you're going to see it in all muscles. Now, I don't think anyone was able to say, let's say take Emery Dreyfus. They would have the distal, the humeroperoneal. FSH, they have proximal and distal. So they have the foot drop, the FSH muscular dystrophy. They have the proximal weakness, scapular winging, and they would have TA weakness. I don't think there has been any work to say why they have this pattern depending on the distribution of these proteins. John has something.
Oh, I was just wondering how these presentations differ from the people who have sort of intrinsic enzyme defects, adenosine dikinase and
glycogen storage diseases?
Well, not just glycogen storage diseases, but there are carnitine palmitoyl transferase deficiencies, and there's these sort of energy producing metabolic problems.
I started with talking about obstructive myopathies. Now I moved to dystrophies. I think that might be a good talk for next time, metabolic myopathy. But let me summarize it very quickly. It depends on what kind of storage disorder are we talking about. Glycogen disorder or lipids disorder. Now we say lipids metabolized by type 1, it's the most common. It's the fatigue resistance fibers. Just follow me for a second. So type 1 is the fatigue resistance fiber that metabolize lipids. Type 2 is the one that is fast twitch, but fatigue very quickly, and metabolize glycogen. So I can tell you that patients with carnitine deficiency or other lipid disorders, they will have trouble doing their regular daily functions. So they will tell you, I cannot really work 8 hours. I have to work only 4 hours. I can't do my grocery shopping. Things that you need a kind of like a continuous production of this energy. Why? Glycogen disorders, acid maltase, they will be normal people. They will have a normal life. They will be able to function very well. But if they have to run to catch a bus or to catch a elevator or something, they might end in red. So that kind of...
But usually their CKs are normal.
The CK to start with, exactly, yeah. So out of their problems, the CK might be slightly elevated, like no more than 5 or 10 times the normal. While with muscular dystrophy, you're going to see the 10 times, 100 times increase.
Considering that type 1 fibers are predominantly involved, and we know that the muscle type is determined by the innervation.
Exactly, by the motor neuron.
Has anyone ever looked for motor neuron pathology in people with muscular dystrophy?
You mean to see if there's any motor neuron problems?
Yeah.
Now, simply you can tell that from doing the nerve test, and like when you don't see any neurogenic problems, and all these, and that's why we say we try to avoid doing muscle biopsy from TA or gastrocnemius, so you will not be missing or misled by an old chronic radiculopathy that can give you a neurogenic picture. Now, when we do, let's say this muscle biopsy, this is a normal distribution, the checkboard distribution. When I'm going to have muscle pathology, let me run to the dermatomyositis. I think it would be very close. So, look at the slide down here. It's kind of still like normal distribution. It's kind of a mess, different colors, different places. While if I'm going to look for a neurogenic problem, then I'm going to lose the motor neuron. I'm going to have other motor neuron pick up these myofibers with what we call reinnervation. And that will give me a picture of grouping. So instead of having this dark, that dark, that dark away from each other, it's going to get together. Why? Because the motor neuron that innervating this fiber and that fiber and that fiber being lost will be picked up by the motor neuron that innervating this one, and that's reinnervation. So you're going to see like a pulp of same color, same type of myofibers. So definitely there's, I would say, from the nerve test, from the muscle biopsies that we do on all these patients, there is no neurogenic problems.
So you think, are there any conditions that are helped with androgens or anabolic steroids as opposed to catabolic steroids?
Why do we think prednisone helps Duchenne muscular dystrophy?
Now, definitely there is no inflammation, but is it possible that because you have all this degeneration, you have an activated immune system that's trying to eat up these damaged muscle fibers? So possibly that's what it is. And anyway, you're using a very small, tiny dose, like 5 to 10 milligram a week. So we know that it will not affect the outcome, it will not affect the cardiac function, it will not affect the respiratory function. But if you started at an early age, and on the other hand, we try to kind of delay it till they are 5 or 7 years old before we started. And it's basically the function of steroid will be to keep these people walking for a couple of years more. So nothing solid about why it's really functioning very well, because otherwise you have to start it in a very early age. And 1 in 3,000, we should screen everyone there for Duchenne and start from the time they were born. That really doesn't work that way.
Are there studies to support that prednisone help? I mean, long-term studies, like randomized?
Randomized, long-term. And this is nothing new. Prednisone has been in use for 10 years.
Yeah, I know. I was just wondering if that was just experience or just...
No, it's and there is a recommended dose of 0.75 per kilo per day. Okay, thank you.
Have a good weekend.
You too?
Oh, sure.
H8, 930. Okay, sounds good. Let's see, who else do we have on the team? So I'm the chief. Okay.
So that's what we need more muscle stimulus to tell you how much is your muscle stimulus.
Chan is the general medicine unit. Who's taking care of the consults? Very good. See you at 9:30.
By doing